So I think we can get going now. Welcome everybody. Thank you very much for joining from many corners of the world, of the globe. My name is Emily Mates and I am one of ENN's technical directors. I've been working for ENN for around 10 years now, so I've come across many of you in my work. We're delighted that everybody can join us. Do please introduce yourselves in the chat box. Unfortunately, with these webinars, you can't see who else has joined, so do please say hello. And today, what we're going to be talking about is that is the launch of a technical briefing paper that here at ENN we've been working on for about a year now, actually. Because it's a very large topic and there was a lot of evidence to review and collate, and we hope that we've done justice to it for this important subject. The agenda for today, I hope you can see on the slide. So we're going to start with an overview of key findings and recommendations from the paper, and then hopefully there'll be a bit of time for questions and answers from you all. So again, if you could just post your questions in the Q&A box, that would be brilliant. In the Q&A, you can put them in the chat as well, but in the Q&A box there is an option to like or sort of vote on the questions. So if you put them in there, then others can also say, oh yes, that's a good question, and then we can prioritize them. We're then going to go to an expert panel. We have some brilliant people who we will have on our panel. And again, hopefully there'll be a bit of time for some questions from the audience after. So a bit of housekeeping. Everybody's audio and video will be off except for the speakers. Hopefully it would have told you as you joined, but we are recording this session and we will subsequently put this up on the website. So I'm now going to hand over to my lovely colleague, Dr. Natasha Lelyveld. She's one of our brilliant senior nutritionists at ENN, and she's going to give the overview of what the paper covers. Tash is actually based in Malawi, and many of you will know that there was a tropical cyclone there a few days ago, which has caused havoc on many levels, but also with internet connection. So if Tash gets cut off, I'll step in and finalize the presentation. So hopefully it won't be too much of a surprise if we've got a change in presenter. Over to you, Tash.
Thanks, Emily. Yeah, and fingers crossed for a good connection. Well, thanks everyone for coming. Yeah, like Emily said, I'm Natasha Lelyveld, one of several ENN authors on this technical briefing paper on women's nutrition. So I'll just give a quick 20-minute overview of what's included in the paper. So hopefully you can all see the slides. Next slide, please, Emily. So what's included? This is basically the table of content of what we cover in this paper. We cover the global goals and targets related to women's and girls' nutrition, current international guidelines, how to assess and the reporting of nutritional status. We did an evidence review of nutritional vulnerabilities of women and girls, and then also the factors influencing those. And then we have a special section focusing in on the vulnerabilities in humanitarian context specifically. We then summarise interventions currently taking place or recommended under the following headings: supplementation, health-related interventions, and then nutrition indirect interventions. Excuse me. Social protection, education and counselling, agriculture, and empowerment. And lastly, and most importantly, we cover the key gaps and recommendations. Next slide, please. So the rationale behind this document was that we know malnutrition disproportionately affects women and girls. And when I say malnutrition, I'm talking about undernutrition, overweight and obesity, and micronutrient deficiencies. We have more than 1 billion women globally experiencing at least one form of malnutrition. So while women and girls have biological vulnerabilities to certain forms of malnutrition, such as anemia, there's also economic, social and cultural factors that are contributing to inequalities that further limit their access to good nutrition. In 2013, ENN published the Maternal Nutrition in Emergencies technical background paper. And this was very much focused, as it says in the title, on maternal nutrition and also humanitarian contexts. So a huge amount of work has already taken place since 2013, so we felt the need to update the evidence in this area. There's still quite a lot of gaps remaining, so we wanted to highlight those and also expand the topic beyond maternal to capture women and girls more broadly and also development contexts. And the technical paper that we've written that we're launching today aim to update and expand the evidence, as I've said, summarise the current international guidance, and also explore what strategies and interventions are currently being implemented. Next slide, please. So I'll just go into some detail on what is within the report. So starting with the global goals and targets. We found that a lot of the global and national indicators and targets were quite heavily focused on infant and child outcomes. There are some really important ones out there, though, however, such as the Sustainable Development Goals. Pregnant and lactating women and also adolescent girls are captured within Target 2.2 to end all forms of malnutrition. And we also have Target 3.1 to reduce global maternal mortality rate. Within the World Health Assembly targets, another key global set of targets, we have a 50% reduction of anemia in women of reproductive age. And then another certainly relevant one, but unfortunately infant child focused, is the 30% reduction in prevalence of low birth weight. Next slide, please. So current international guidance. The international guidelines that do exist for women's nutrition are quite heavily orientated towards the antenatal period and also micronutrient supplementation. We found quite a number of international guidelines that contain important information for women's nutrition. However, they were quite piecemeal, so in bits and pieces in different documents, and we found this especially to be true for the humanitarian context. For example, advice on supplementary feeding for moderate and severely wasted women is either limited or absent at the moment. We also found that some of the guidelines weren't consistently updated, and locating the latest could be a bit difficult. And we found that sometimes you'd get different guidelines that didn't reference one another, and also differing guidance on the same topic across different documents, which is obviously not ideal. Next slide, please. So just highlighting some of the current key international guidelines that we did find. The WHO 2013 postnatal care guidelines have some really important information on iron and folic acid supplementation and nutrition counselling in the postnatal period. A really key one is the WHO 2016 antenatal care guidelines, which cover a large number of nutrition topics, including dietary counselling, balanced energy and protein supplementation, so that's BEP. That's for undernourished populations specifically, and then a broad range of micronutrient deficiencies and also caffeine intake. Then there's also the 2019 Essential Nutrition Actions, which are a little bit more infant and child focused, but do have some very relevant ones for women, girls and mothers. And there's also a large number of UN nutrition guidelines for populations in humanitarian context, which cover general populations, of which obviously includes women and girls, and also have some specific guidance on women and girls and mothers, including supplementary feeding, micronutrient supplementation and dietary needs. And lastly, there's a number of different Lancet series publications that have some really important recommendations for women and girls nutrition. Most recently, the 2021 Lancet series on maternal and child undernutrition that had 5 key recommendations, including iron and folic acid supplementation for non-pregnant adolescent girls and women of reproductive age, counselling on diet during pregnancy, multiple micronutrient supplementation, MMS, in the antenatal period, calcium supplementation in populations at risk of low intake, and balanced energy protein supplements for undernourished women. Next slide, please. Now going on to assessment and reporting of nutritional status. We found that there was need for a bit more guidance and clarity on how to assess nutritional status of adolescent girls and women. There's, for example, no universal definition of wasting in pregnant and lactating women, nor in adolescent girls. There's no formal definition of underweight in pregnancy, no consistent definition of low stature or stunting in adult women, and also we don't know the optimal MUAT cutoff in different contexts. So we did find some really key gaps there. There's also a lack of data on pre-pregnancy BMI and gestational weight gain, so it's quite difficult to know what a healthy pregnancy weight gain looks like, and if it's unhealthy, what interventions should be implemented. We do have some really important nutritional status indicators included in global and national monitoring, including the DHS and the Global Nutrition Report. So they cover short stature, underweight, anemia prevalence, overweight and obesity, prevalence of diabetes, and also high blood pressure. However, there isn't currently any monitoring of minimum dietary diversity or any other micronutrient deficiencies for women and girls. And another important gap in this area is the lack of data for adolescent girls, especially at the younger end of the age range. So 15 years and older, girls are sometimes included within women of reproductive age, but they're usually not disaggregated. So again, it doesn't tell us much about adolescents specifically. Next slide, please. So the report then goes on to cover the evidence in terms of nutritional vulnerabilities for women and girls. As I've mentioned already, that's underweight. We cover overweight and obesity, gestational weight gain, and also micronutrient deficiencies, which I won't go into detail here. We've only got 20 minutes. Next slide, please. The report also covers influencing factors that I've described here: dietary diversity, seasonality, COVID-19, climate change, mental health, early marriage and adolescent pregnancy, and postnatal care. Next slide, please. So the report then goes on to cover and describe interventions that are currently recommended or being implemented for women and girls, and I'll go into a bit more detail here. So the majority of evidence that we found for women's nutrition programs focused on macronutrient and micronutrient supplementation, and that was generally to target undernutrition and anemia, largely in pregnant and lactating women and girls. We did find some gaps in this in these interventions, and particularly the guidance around wasting, defining wasting, anthropometric definition, and also what type and quality and content of supplementary food to provide in wasted or undernourished women. There is the new guidance on balanced energy and protein supplementation, which is great, but it is relatively new and does seem to lack detail and also implementation guidance. We really need more examples of how that's been successfully implemented in undernourished populations. It's also slightly confusing how this new BEP guidance aligns with existing guidelines for liquid nutrient supplements or other supplementary foods given, especially in emergency contexts. For example, some LNS products qualify as balanced energy proteins, but some do not. And additionally, there's another key difference is that balanced energy protein supplements aren't usually fortified with micronutrients, whereas LNS are. So we just need to know what should be given when, which guidelines should take precedence in certain situations. So there's also currently no standard criteria for the inclusion of pregnant and lactating women and girls in blanket feeding programs in emergencies. And also coming back to the content of supplementary food, we didn't find any recommendation on the content of essential fatty acids within supplementation, even though there is strong evidence to show it has a positive effect on preeclampsia, prenatal depression, placental weight, and infant birth outcomes and growth. Slide, please. So one of the most advanced areas in terms of women nutrition evidence and programming is micronutrient supplementation. The evidence is very clear that it has established benefits for maternal anemia and birth outcomes. However, there has been some recent debates on differing interpretations of the evidence in terms of whether to give antenatal iron and folic acid, or whether it's better to give antenatal multiple micronutrient supplements, MMS. Besides, during pregnancy, IFA supplementation is also recommended from other subgroups, including non-pregnant girls and women in high burden contexts, and also postpartum for 3 months. We do still think that the guidelines for micronutrient supplementation could be strengthened in terms of implementation, how to get a better coverage, and also how to improve adherence. And this is particularly true for non-pregnant women. Next slide, please. So health-related interventions, these are highly important given that the nutrition of adolescent girls and women is integrally linked with the provision of health services. Health services provide an important contact point for nutritional assessment, for counselling, for referral, and for delivery of interventions. We did find that integration of maternal nutrition within health services could be a lot better. Nutrition services within antenatal care is really well established, so that's a real success story. However, we need more of a focus also on postnatal nutrition and also nutrition of non-pregnant women and girls. So issues that affect health systems, including inadequate human and finances, lack of availability and poor quality commodities, inequitable resource allocation, and a lack of accountability mechanisms, all have a really negative impact on women's nutrition. And that's why health system strengthening and capacity building needs to go hand in hand with our nutrition programming. Next slide, please. So just the report goes into some more detail in terms of specific health-related interventions, including infectious disease, non-communicable diseases, NCDs. So the WHO Global Action Plan for Prevention and Control of NCDs is a really key document here, and has quite a number of nutrition elements mentioned, including healthy diet, reducing salt and fat intake, more fruit and vegetables, eating more plant-based foods. However, the evidence within this document is quite largely focused on high income settings, so it'd be great to see that updated with more evidence from low and middle income settings. Also mental health interventions and breastfeeding care and support. So we know obviously that breastfeeding is vitally important for infants, but it also has important health benefits for women. Next slide, please. So now the indirect nutrition interventions. These really are some of the most lacking areas in terms of our current guidelines and programming and policy. We need more evidence to inform the development of multi-sectoral programs. And for example, while the supply of an intake of micronutrients has increased globally, this is not necessarily equated in a higher intake by women. And that really highlights the importance of gender empowerment and impacting on women's nutrition. And we're not currently seeing gender empowerment mainstreamed within nutrition programming. Another area that we really felt could be strengthened was links with climate change. So there's some great programs in terms of climate change and agricultural interventions, but they often fail to consider the specific impacts on women. And it's women who are most likely to be affected by food insecurity as a result of climate. Next slide, please. So now I'm just going to finish off by detailing the key gaps and recommendations that we list in our report. Number one was that navigating and finding the latest guidelines on nutrition for adolescent girls and women was quite challenging. The WHO have a great e-library called ELENA, which is a good collation of all nutrition guidelines generally, and it would be really great to see something similar for women in particular, and so you could find the latest. It would also be great if new guidelines could reference each other, and if we had more documents like this one we've just created where we can synthesize the recommendations all in one place. So number 2, there's a lack of evidence or guidance on preconception nutrition, especially in adolescents. We did find that global targets, indicators, policies and programs were largely focused on pregnant women, and we need more for non-pregnant adolescent girls, given the importance of the preconception period. Number 3 was global and national indicators are heavily focused on infant and child outcomes rather than outcomes for the mother herself. Going forward, we really want to see disaggregated indicators and targets for adolescent girls, for pregnant women and for non-pregnant women, just to be really comprehensive. So number 4, there's a lack of guidance and clarity on the assessment of nutritional status in adolescent girls and women. As I already said, number 1, there's no optimal context-specific MUAC cutoffs. There's no routine collection of dietary adequacy indicators. And number 3, there's a lack of global data on gestational weight gain, all which gaps that need to be filled. Next slide, please. So number 5, there are contrasting interpretations of the evidence based on whether IFA or MMS supplementation should be used in pregnancy. And this is a really important hot topic at the moment, and a bit of a sticking point that we need to clarify in order to move forward with programming. And it would be great if we could have a consultation between the organisations that hold contrasting views and really move forward on this issue. Number 6, there are gaps in the guidelines for macronutrient supplementation in undernourished women. We found no guidelines on identifying and treating wasting in women. The new BEP guidelines, like I said, it needs more implementation guidance. And we'd also like to see some inclusion of mitigating the risk of NCDs when we talk about macronutrient supplementation. Number 7, there's a lack of indirect nutrition interventions. And as I've already stressed, we would really need to see women's empowerment, maternal mental health and climate change mainstream within nutrition programming. And number 8, there is a lack of integration of nutrition services for women within health systems. So beyond antenatal care, we want to see more nutrition services postnatally within health systems and also for non-pregnant women and girls. Last slide, please. And this is just to thank our generous donors, USAID, Irish Aid and the Eleanor Cook Foundation for funding this work. Thank you.
Thank you so much, Tash. Delighted that you managed to stay with us for the duration. So it was a very interesting presentation, and yeah, it was very clear and concise. So thank you for that. We do have time for a couple of questions before heading into the panel discussion. So before we start that, I just want to introduce another one of my excellent colleagues. And he's Dr. Philip James. He's a senior technical associate with ENN, and he's been leading on this work with the team. So Phil and Tash are going to be ready to answer questions, and I've just got to open up. Yep, I've just got to open up my WhatsApp to see the first question, which is, and I'm not sure which one of you who's going to answer it, but Phil and Tash, maybe you can decide. So yeah, who do you think is best placed to help keep the momentum and maintain accountability for these recommendations?
Shall I start?
You do.
It's great to be with you all, and a fantastic question. I'm not sure who asked that, but certainly something at the back of our minds. To be really transparent, we've got to the stage of compiling this report and writing down these gaps and recommendations. And the next step is going to be, I guess, the most important and an even bigger phase of working out who takes forward these recommendations and keeps everyone accountable. And I think we're all going to be involved in that as a nutrition and health sector community. There are certainly, I think, areas that ENN could facilitate if the opportunity arises, more convening on decision makers, pushing forward accountability suggestions. But there is such a big scope of work here that we're going to need everyone's support and ideas. And I think that's a great question, if we have time later on, to put to the panel members as well, who are probably much better placed than me to answer that. So we'll come back to that as well, if that's okay. But Tash, I don't know if you have anything else to add there.
No, I think that's great.
Thank you. So another question that's come in while Tash was talking, and maybe I can ask you to have a go at answering it, Tash. So the question is, in the absence of clear guidelines on anthropometry to assess micronutrients in adolescents, MN, I think that's micronutrients, there's not very much research around the potential, MN will be malnutrition in this case. Malnutrition, okay.
Yeah.
So in the absence of clear guidelines to assess malnutrition in adolescents, there's limited research about the potential for MUAC for age, for assessing it in adolescents. So according to this review, what type of data could be collected to contribute to data generation on this topic? And I think you're the perfect person to direct this to, Tash. You've been very involved in adolescent anthropometry.
Yeah, there is a few pieces in adolescents specifically on MUAC for age, and I think there's some hesitation. It probably comes from high income settings because MUAC's not very good at picking up overweight and obesity, but it is pretty good at picking up risk in terms of underweight, thinness, wasting. So I do hope that we do get some more evidence and policy move on MUAC for age in the adolescent age group. And then for pregnant and lactating women, I think we're already moving towards a 1 cutoff for MUAC without the need for age-adjusted Z scores. Lots of organisations and some of the guidance actually do mention specific cutoffs, but there isn't an official definition still. So we'd really just like to see one definition, or perhaps some regional or context-specific definitions for MUAC in pregnant and lactating women.
Great, thank you. Yes, adolescent anthropometry is one of the most confusing areas at the moment, with very little clarity. Okay, I think we've got time for one more question, and I'll direct this one to you, Phil, so hopefully you will be able to shed some light on. So in terms of identifying malnutrition in women, again, it's a question around MUAC, but how effective has the MUAC cutoff point of 21 centimetre or BMI below 18.5. So these are the current guidelines we use for our field programming. So I think the question is around effectiveness of those particular cutoffs.
I think there are a number of countries that do adopt MUAC less than 21 or MUAC less than 23 centimetres for supplementary feeding for pregnant and lactating women. And I think Abby would be really well placed to answer some of that, because the World Food Programme takes a lead in addressing these needs and has a lot of case studies showing the effectiveness of this. What I think we are missing is more details on the type of intervention that's needed, the dosage and discharge criteria. There's a little bit more out there for moderate wasting in adolescent girls and adult women, much less so for severe wasting. And I think there really is a gap of effectiveness of some of these approaches. Acceptability as well is missing often. So certainly in humanitarian context, we're finding evidence on efficacy, effectiveness, quite hard to find, quite piecemeal. There are anecdotes out there, and I'm sure there's a wealth of information in the grey literature within institutions, but it's quite difficult to access this from the outside. So that was what we hoped we could try and make some steps towards consolidating experiences in this report. But in doing that, we realised quite how big the gap is for this evidence.
That's great, thank you. And if you can look in the chat as well, some of the experts listening in are managing to provide some good information as well. So do have a read of those. Okay, I think it's time now we move on to the panel discussion. So now I'm going to hand over to Phil, who's going to facilitate this. Thank you.
Thank you, Emily. We're really delighted to have 6 experts in the field of women's nutrition and health to join us in sharing their reflections on the technical paper, also, of course, to give us their additional thoughts and wisdom. I'll introduce each panelist in turn, and I've asked each of them to prepare a very short reflection of a couple of minutes on a particular theme. Each panelist brings a wealth of experience and much more than I can do justice to in a brief introduction. So I'm going to ask my colleague Sophie to copy and paste fuller biographies of our panelists in the chat as I introduce each one. As you listen to the panelists' reflections, please do ask any questions in the Q&A area, and we'll be making time to put your questions to the panelists in the next part of the webinar. So I'd like to invite Dr. Basir to the floor. I see you've shared your video. Thank you for joining us, Dr. Basir. Dr. Basir Khan is the Senior Director of Health Regulations and the National Nutrition Programme within the National Health Ministry in the government of Pakistan. He's had a really long and impactful career spanning decades. So thank you for joining us, Dr. Basir.
Thank you. Thank you. Thank you.
Welcome.
Yeah.
So the question that we asked you to reflect on, just to let everyone know, is what do you think we need to do to help women during pregnancy to improve low birth weight rates, but also to improve women's own health outcomes? We'd love you to share experiences from the government of Pakistan, and over to you.
Yeah, thank you, Phil. Thank you so much for inviting us and giving us this opportunity. First of all, let me appreciate your whole team for such a wonderful document you have developed. While going through it, honestly speaking, it speaks very well of all the interventions or all the gray areas with regard to the woman in adolescent nutrition. It is a super document, I must say. And just after a small scan, you know, a very quick scan, I saw each and everything in it, which really matters. And the recommendations are excellently lined up, which very much needed for all of us, the developing countries, to look into the transform it into policies at the earliest. I just will request that, being a representative of 225 million population country, Pakistan, which is one of the largest one in the region, especially, we contribute a lot of bad indicators with the world. And keeping that in mind, so I will just focus on 2 or 3 things that each and everybody knows, that the educate nutrition is the foundation cornerstone of any individual health, especially. But in Pakistan, women of reproductive health are facing triple burden, malnutrition, undernutrition, overweight, obesity, and micronutrient deficiencies. And the National Nutrition Survey we last carried out in 2018-19, which reflects a very bad status, and like 15% of women underweight, 25% of prevalence they are overweight, and 14% are obese. This is a very high prevalence of 42% of Pakistani women are anemic. So women in Pakistan, you can say they are destitute and deprived by various factors, and each of these factors create a vicious cycle which negatively impact women's health, and in turn their children a chance at a healthier life. The intersection of social and economic factors limit women access to nutritious food. So in most marginalized population, due to lack of the resources, women prioritize their family members' nutritious over their own, and often forgo their own nutrition. This triggers a cycle of nutritious deficiencies nutrition deficiencies as expert have concluded that women who weight less than 100 pounds are more likely to deliver prematurely or give birth to an underweight baby. The status as such has not been changed since long. And in Pakistan, especially, the biggest issue, the early marriages or the low attention on the adolescent health, or the you can say that the marriages age started from 13 to 14 or 18, which fell this lady, this young girl, into a vicious cycle, which she could not, aggregate throughout her life cycle, borning 2 or 3 or 4, 5, very frequently babies in her life. But currently in Pakistan, the good news is that Pakistan, we have started a case transfer program, especially which is conditional with the diet or nutritious support to the women of Pakistan, especially the marginalized or the low-income population, which is currently in 50 districts, this program. And with the intervention or the prioritization of the current government, I have been asked by the government that to develop a program, a huge program, which is almost $2 billion program, which will be focusing on adolescent girls, the women of reproductive age, or the also the children of almost, you can say, in 67 districts of Pakistan, which half of Pakistan account for that. So that is one area which one can hope that if we invest on this area especially, so maybe in the coming 5 years, the scenario will be a little bit changed. And secondly, Pakistan is also currently a pilot country for universal health coverage for overall health care. Utmost importance has been given to the antenatal care and deliveries by skilled healthcare provider, and special support has been provided during the last 5 to 7 years through a special protection facilitating the pregnant and lactating women for utilization of healthcare and delivery services. This has dramatically increased the birth occurring at health facilities from 48 to 66%, which ultimately has affected the health of the woman as well. And under the guidance of the Prime Minister, when we developed this program, so this program has been shared with all UN partners, civil society, the other nutrition partners. So they are considering certain areas of the intervention which are women specific, adolescent girl specific. So they will be working with us. But it is a high time that the major stakeholder, the UN agencies, CSOs, and development partner must act together with the government everywhere in the world to address the menace of the general malnutrition. I do agree with the recommendation of your paper, which is excellently chalked out. There should be a clear guideline for use of weekly iron folic acid for adolescent girls, MMS for pregnant and lactating women, and SNF to target malnutrition among mothers. So if we a little bit more focus on women, the women-centric approach, which the current government has asked us to do. So it is hoped that in the coming 5 years, the agenda of only targeting the children, if we target a little bit more the mothers as well, or the adolescent girls as well, I think the scenario of the maternal nutrition will be improved in Pakistan. So this is from my side. Thank you very much, Philip.
Thank you
for inviting me.
Thank you for sharing those experiences and such encouraging news about that $2 billion program. Really wishing you luck and your government members planning that. And I'm sure we'll be coming back to you to ask you more questions on your strategies. Thank you. We're going to turn now to Hiwot, who is our next panel member, and I'd like to invite Hiwot to share her video, if she's able. Welcome. Mrs. Hiwot Darsene joins us from Ethiopia today and is the nutrition team coordinator for the Federal Ministry of Health in Ethiopia. So a warm welcome to you, Hiwot. And just checking that you're able to hear us okay. You're currently on mute.
Okay.
Oh, great. We can hear you.
Okay. Good afternoon or good morning, everyone.
Good afternoon, Hiwot. Thank you so much for joining us. Let me just share with the participants the question we asked your reflections on. The theme was concerning the integration of nutrition services into health systems, of course being such an important part of improving coverage of critical interventions. So we'd love to hear how Ethiopia is using various platforms to integrate nutrition services within the national health system. Over to you.
Okay, thank you, Philip, and the organizing team. It is my pleasure to join and share the experience of my country, Ethiopia, about the integration of this nutritional service specific to maternal and adolescent nutrition service. So here in Ethiopia, there is we follow 3 health tier system that constitutes the primary hospital, health centers, which meant to serve 15,000 to 25,000 population, and under each health center there are health posts, which meant for 3,000 to 5,000 people at the lowest health system, which is at the grassroots level, at the household level. So in each of the health posts, there are 2 health extension workers deployed. This is more than 14,000 health extension workers at the grassroots level, which are given the basic services in 18 package. So nutrition is one of the package in health extension workers. So this is one of the platform, and in terms of policy landscapes, we do have food and nutrition policy, which was endorsed in 2018. So following that, for this successful implementation, we do have food and nutrition strategy, which is used to we going to use for the coming 10 years. So it was designed from the food-based approach and in life cycle approach. So maternal nutrition and adolescent nutrition is key and critical. So following that, we have in preparatory stage for revising this adolescent, maternal, infant and young child feeding nutrition. So these are in terms of policy landscapes and guidelines. So as mentioned earlier, these health extension workers are responsible for providing maternal nutrition services in terms of this antenatal care. So during this antenatal care, they monitor the weight of mothers, they give iron folic acid supplementation, they advise about healthy diet and extra meal, iodine, salt use, and so on. So they are intended to report to the next tier system. So the information system is also integrated in the national health information system. So they are accounted for any services and they are expected to report all the services provided at the grassroots level. The other one is in terms of for adolescent girls, we do also use the platforms like a school. So we are delivering in more than 100 districts the weekly iron folic acid supplementation, the intermittent one. So we are using the school platform for this adolescent girls at school, and we are on the verge of devising to reach out these out of adolescent girls. And the third main thing is we are not so far we are not providing the pre-conception care, but we are trying to incorporate or mention in our strategy, food and nutrition strategy and reproductive health strategy. So we are in the preparatory stage to implement or to interpret into the implementation guides. So we are going to start in a few years, in a couple of few years, the pre-conception care, which is mainly in different platforms like school, community, and health facility platform. So other services like the postnatal and family planning clients are also used to be counseled about nutrition services or maternal nutrition services, supplementation, and healthy lifestyle. And in the long run, we also include to the non-communicable diseases. We are mainly on communicable illnesses like malaria, because it is a public health problem in the context of our country. So we are promoting the use of insecticide-treated net and malaria treatment as per the national protocol. So in as much as possible, we are also linking this maternal service not only in the health sector or in the health system only. We are trying to utilize efficiently other nutrition sensitive areas like productive safety net programs. So we are using this safety net program for the poorest of poor or and the food insecure households. If mothers are or pregnant and lactating mothers are identified from these food insecure households.
Sounds as though there's an example for every section of a technical paper in Ethiopia. It's really quite inspiring. Thank you so much. If I could just, we'll come back maybe for a few more stories and experiences. But just to say, we've been so inspired in previous years at the example of health extension workers from Ethiopia, that system, and the integration into of nutrition services into the health system is really inspiring. And we are definitely going to be looking to you for your experience with their preconception work. That's really exciting to hear. So I'm sorry to cut you a little bit short, but just to get around the other panelists, and we will come back to some of your stories. Thank you for joining us, Hiwot.
Okay, you're welcome. Thank you.
Fantastic, thank you. Our next panel member is Dr. Charlotte Warren, and Charlotte leads the maternal and newborn health research portfolio at Population Council, and she brings to us so much expertise on health system strengthening and health research for policy and programming. So thank you so much, Charlotte, for joining us, and I'm going to invite you to share your video and unmute if you're able. And the reflection that we asked for you for, so given that current global targets and indicators are heavily focused, let's say, on infant and child outcomes, although sometimes anemia in women as well, what do you think is the most urgent gap in targets for women's nutrition?
Thanks, Philip, and thanks very much for the opportunity to be part of this panel on the launch of this extensive work, where several gaps for women and girls' nutrition has been highlighted. As mentioned in this briefing paper, maternal nutritional status at the time of conception, during pregnancy and through lactation is an established determinant of child survival, growth and development. However, global and national indicators are heavily focused on infant and child health outcomes and few on her mother herself. There is a dearth of global data on pre-pregnancy BMI and gestational weight gain. We know that around 290,000 women die every year due to pregnancy-related complications, but there is much less information on the extent and detail of maternal morbidities, including malnutrition among these women. To end preventable newborn deaths and stillbirths by 2030, the annual number of neonatal deaths, stillbirths and maternal deaths could be reduced by 2.5 million in 81 high-burden countries by 2030 if care, i.e. known evidence-based practices, including nutritional ones, are scaled up along the pregnancy postnatal continuum. And this includes from pre-conceptual nutritional care, which the previous speaker has emphasised, as well as care of the newborn once they're born. And there have been many improvements in the last decade, but we know that there is still access to comprehensive services is low, especially among marginalised groups living in urban slums and humanitarian fragile settings. There's need for a much more effective use of coordinated resources for maternal health along the continuum. And we really should focus the shift to woman-centered care or adolescent girl-centered care, responding to the woman's health, nutrition and information needs. The routine tracking of progress and the collecting and using data for maternal health indicators really only focus on the antenatal, as has been said, the antenatal contacts a woman has, who attends during childbirth, and very early routine postnatal care, which is within 2 days of birth. But the quality of the content of these contacts within the health system is very variable, especially in some low resource settings. And many settings, as we know, adolescent girls and women do not seek care till very late in pregnancy due to the weak health system, lack of supplies, but also unfriendly health providers. Thereby, these girls and women are missing out on any opportunities to receive optimum nutritional supplements. Not only that, there are so many missed opportunities in taking care of a woman's nutrition and health, which persist into the extended postpartum period, with very few women being followed up beyond the 6 weeks. And the first year after the child is born, there are many opportunities to engage with the health system. Women bring their babies back for immunization, but nobody ever seems to actually ask the women how they're feeling and respond to their needs. Also, the burden of overweight and obesity in certain parts of the world in adolescent girls and young women increases the risk of pregnancy and childbirth complications. For example, the risk of developing gestational diabetes and hypertensive disorders of pregnancy, leading to increased risk of preeclampsia and longer-term risks of cardiovascular disease, kidney disease, and other NCDs, as well as intergenerational risks of diabetes in children and grandchildren. In a study that Population Council conducted in Nigeria, we demonstrated that women with hypertensive disorders of pregnancy were associated with a higher incidence of metabolic syndrome, and high BMI was a significant risk factor for persistent hypertension at 1 year. Measuring what happens in the extended postnatal period, both the content and the contact, is critical. So in conclusion, the nutrition, information and services need to be fully integrated within comprehensive women-centered healthcare, and especially in the extended postnatal period, especially in recognizing women's risks in regard to future pregnancies and risks of NCDs. Refocusing investment on the greatest burden of deaths and disability is required to improve women and adolescent girls' health. High quality universal healthcare is a right for every child, adolescent and women everywhere. Thanks.
Thank you so much. Thank you, Charlotte. And for really addressing that critical, the extended postnatal follow-up that's needed. And I think actually that touches, I noticed a question pop up in the chat from Mia on this postpartum follow-up. And if we've got time, just as a heads up, I think it'd be really interesting in the discussion if we can learn, why don't we do that? We've got the evidence to suggest it's very important to continue this focus, but why is that not happening routinely when we should be? So if we've got time, I'd love to come back to you, and that will answer one of our questions, just to give you some advance warning.
Okay.
So thank you. Fantastic. We're going to move on to our fourth panelist, who's Abigail Perry. Abby is the Director of Nutrition at the World Food Programme, and many of you will also have known her in her previous role as Senior Nutrition Advisor at the UK Government's Foreign, Commonwealth and Development Office. So a warm welcome, Abby. Thank you for joining us. It's great to have you joining us from Rome. And for your reflection, we asked you to take the topic of balanced energy and protein supplementation, which is currently recommended for all pregnant women in context with a high prevalence of underweight. However, there are many barriers, as we know, that mean coverage is currently low for underweight women in need of support. So in your opinion, what can we do to take this latest recommendation forward to implementation at scale?
Thanks very much.
Question.
Yes, more. Thanks so much, Phil. And just to say an enormous thank you for, I think, a very long overdue focus on a really important topic. And I think the reflection on the importance of considering the nutrition of women and girls more broadly, and not only during pregnancy and breastfeeding, I think is really important for us to keep in mind. But coming to the question that you posed, I mean, obviously, as many will know, WFP has provided targeted nutrition support to women during pregnancy and breastfeeding where possible for quite a long time. And so the question of what it means to use or think about BEP supplementation is one that has been at the forefront of our minds. And indeed, we've been working very closely with the government of Pakistan, which is one of the contexts in which there is a kind of consideration of how to really take this to scale to support particularly vulnerable women. There are multiple barriers, as you mentioned. There are, I guess, probably 4 or 5 quite interlinked that seem to be coming out that we need to really think through how we can focus on as we move forward on this. The first one is really thinking where we're planning on using a supplement, a pre-prepared product. Not saying that has to necessarily be the only solution, but where we are fundamentally talking. I think we need to make sure that we're really properly investing in understanding what is going to be desirable and actually consumed by the women that we need to prioritise. We know that it's been quite challenging to make sure that products that aren't meant for women actually do get consumed by women. So really understanding the barriers to that and ensuring that we've got approaches that really work for them are very important. Linked to this, there is then a question about how to ensure we're reaching women who are particularly at risk. I mean, obviously, we know that we need to maximise antenatal coverage, antenatal care service coverage, but equally how to make use of other platforms where we reach food insecure women, women who are particularly vulnerable. So in the Pakistan context, there's a very strong link into the social protection programme. That may or may not be the best route to reach those women who are most in need, but nonetheless, we need to consider the different platforms, the way that we can reach the women who are most at risk. Again, all these things are quite interlinked. There's also then a question about, again, where a product is deemed to be the solution, is ensuring that we've got production capability and the ability to get a quality product that's trusted by the women themselves close to where they live. And again, we know that's not a small task, particularly when we consider how other products that we've been using, which are not, they're not designed, or I mean, some of these things haven't been designed for these same purposes, but how to make sure that we can address some of the issues of reaching particularly marginalised populations, considering how to get that out to people in need. I think a binding factor across all of this, though, is the question around the financing model. These products, particularly if we're trying to ensure that we're reaching the poorest women, people who are particularly vulnerable, we know that these aren't going to be products that are affordable. And WFP has spent a lot of time looking at the affordability of good nutrition. And the reality is that for the poorest people, the women who are going to be most in need of this product, we are looking at free distribution. And so then that comes into a question of, well, what are the creative ways to ensure that we can get financing in? We know that there have been different approaches tested around having commercial production for the commercial market, and then looking at how to subsidise or ensure free distribution for people, for women who particularly need support. But there are some interesting challenges associated with that, and that includes trying to get new products to market, actually more generally, recognising that the food market is quite a competitive one. So getting products that are designed specifically to women to market at scale, that can be commercially viable over a longer period of time, is quite a tricky nut to crack. And then I think the final barrier that we really need to work out how to address is the argument for this as a public health priority. So really ensuring that we've got that really solid evidence on the cost benefit of including this. And the work that the likes of the World Bank have done through Optimum Nutrition to help government decision makers work out how to best use resources, point to the importance of making it absolutely clear where you have got quite a high cost associated, again, where, for example, we're using a product, we're really maximising decision making on how to get that right product to those right people and ensure that it's understood as part of a beneficial package that has multiple benefits for the women themselves, but also for for the children that they have as well. So the advocacy and the argument and the understanding of cost benefit is going to be really, really important. Noting that governments are being asked to pay for quite a lot of things, and obviously donors are as well. So we need to make sure we've got the strongest possible evidence in case for that. So not a small task, but I think, and it's going to be quite context specific. So we really need to think about some of these principles, taking kind of country by country. And as I said at the start, they're very interlinked. So I think, understanding this from a system perspective is going to be important once we resolve a number of the mechanics around exactly how we understand the prioritization of targeting for any product or any support like this. I hope that provides some insight.
It does, and it really gives us some ideas as to these next steps, which are the most difficult things that we didn't necessarily write about in the report: production, financing, tying into accountability frameworks that we mentioned earlier. So thank you for giving us a lot of food for thought, and I really hope that all of us can continue this conversation with you. Lots of important ideas, and we'll get you back at the end. Thank you very much, Abby. Our next panelist is Dr. Marty van Leer, and Marty is the Director of Programs at the Micronutrient Forum, where she set up the Healthy Mothers, Healthy Babies Consortium last year, which brings together stakeholders aiming to improve maternal nutrition, specifically through the introduction of multiple micronutrient supplementation. So welcome, Marty. And I asked this reflection to you. So in our paper, we documented the differing guidance on the use of multiple micronutrient supplementation in antenatal care. So that ranges from the more restricted use in research contexts and humanitarian emergencies in WHO ANC guidelines, and then let's say fuller support for MMS scale up, for example, in the 2021 Lancet update. And we made some recommendations about that going forward. And do you have any additional thoughts on what needs to happen at the international and national level to harmonise this advice and help clear up some confusion, maybe?
Mm-hmm. Thank you, Phil. And also thank you, Emily, Natasha, and all of ENN for such a solid, comprehensive, and very timely report. Honestly, if you wouldn't have written it, I think we should have started doing that. Yeah, so this consortium that was set up, Healthy Mothers, Healthy Babies, is focusing on maternal nutrition, but as you said, specifically on MMS, and that's why you asked this question, of course, regarding this seemingly discrepancy between the context-specific recommendation WHO and then the Lancet saying, okay, let's scale up. My point of view here is that, despite the fact that we have 20 years of research on MMS, looking at impact on birth outcomes, there has been very little implementation yet. So it makes sense when considering to maybe transition from iron folic acid for pregnant women to multiple micronutrient supplements, to first really do that accompanied by rigorous implementation research. Because, well, no, first, you know, WHO doesn't say do not implement, right? They say do it in the context of that research. And the issue we're talking about is not simply a replacement from one supplement to another. Actually, there's a lot of the issues that Abby was talking about for BAP that also, of course, are concerned, concern a product like MMS. So I believe there is a need and there is an opportunity to, through this implementation of MMS, also strengthen the nutrition interventions in antenatal care and to overcome some of the existing barriers, such as, adherence to the supplementation of women. But for that, we need to answer questions on acceptability, on feasibility, cost effectiveness, and sustainability of the intervention. So for me, it makes sense that we are now doing that in the context of implementation research so that we can really improve, let's say, this supplementation for women. Currently, there are, I believe, in about 20 countries, there is this implementation research ongoing concerning introduction of MMS. And the results are becoming available, lessons are being learned. And actually, the consortium, so on our website, we have recently done an inventory of who does what where, in, of course, the context of MMS-related activities. And there is a map that really maps it out. So if people are interested, they could take a look at that. I do believe that these lessons learned, coming to your question on, you asked two things. You said, okay, what to do at national level. I do think that there could be more, are you still hearing me? Yeah. Okay. I think there could be, if countries are interested in starting to do that and they really want to know more about implementation research, what does it mean? They could contact us. We can connect them to those agencies and experts that are actually doing the implementation research. We're just hosting a consortium that brings together these experts. So, not having feet on the ground, that are other organizations, but please contact us. We can definitely guide there. The other thing that I believe in let's say, getting some clarity on what is now meant with that research context is that very soon, I believe that the results that come available need to feed into a consultation between the experts that have been doing this research, WHO, to see which of the questions have been answered. But where are there still remaining questions? And then come up maybe with a clear research agenda and defining how should we do that. I also need to say that I am aware of the fact that there's an implementation research guideline or guidance coming out of the MMS Technical Advisory Group. It's still in the works, but should be, I know it's in discussion. The same Technical Advisory Group also has produced a guidance note that kind of interprets the WHO recommendation. I think in your report there was a reference to that. So, by closing, I actually, 2 points, if I still have time. I think that the paper rightly sets out that there is a lack of information, lack of data on women nutrition, or maybe also what they eat. And specifically, I would like to highlight the lack of micronutrient status data, right? And intake data. And just for information, there is a new initiative that's being set up that's called DINA, meaning Nutrition Data Innovation Alliance, really looking into those issues along the data value chain for, what data are there, what is the quality of the data, how do we improve the use of the data or fill the gaps. And they're also going to look at really gender disaggregated data. So just keeping that in mind, I think that might be of interest too. And then finally, I have a question to the audience or the ENN community, if I may, not for now, maybe later. because there is also a WHO recommendation for use of MMS in humanitarian settings, in emergency settings.
Yes.
And that one is unambiguous. So my interest would be who has experience with this? What are the lessons learned? Or if MMS, or if organizations have not yet so much implemented, what are the barriers and what can be done to overcome these barriers? So that's an open question, and I'd love to be working on that together with ENN Network.
Oh, that would be fantastic. We really need more stories on what's working in humanitarian contexts. Thank you, Marty, and for really showing us that I think often we interpret iron folic acid versus MMS and polarize the debate, but you've really shown us how actually it doesn't have to be like that, and some very concrete suggestions. I've done a really horrible job of timekeeping, but thankfully we're being recorded. So I know some of you will be dropping off, but we will be sharing the recording of this on ENN Media Hub. So don't worry, you won't be missing out if you do have to leave now. I would like to keep going. It's just fantastic to have these all these expert opinions. And our final panelist is Dr. Lisa Marie Rogers. Thank you for joining us, Lisa. Lisa is a technical officer in the Department of Nutrition and Food Safety at the World Health Organization. And she's been working in WHO, I believe, for over 15 years, if I've not got that wrong, focusing much of her work on micronutrients. And Lisa, the majority of available evidence on maternal nutrition programs focus on macronutrient and micronutrient supplementation, particularly to tackle undernutrition and anemia in pregnant and lactating women and girls. In your opinion, what are some of the other major priorities currently being missed from women's nutrition programming, especially maybe on the preventative side? Over to you. Thank you.
Thank you, Phil, and thank you again for the invitation to join this panel. It's been a really lovely experience to hear the report, and just again, I'd like to reiterate my congratulations on such a great paper and document. I really enjoyed skimming through that. So because my professional work has always been in micronutrients, I'll provide more reflections from that aspect, if that's okay. And I think we all have a really great appreciation for the supplementation products and the programs around those products, as they have a really valuable role to play in with respect to anemia and micronutrient deficiencies. And if they're used properly and they're implemented in a good manner, they can have the potential to really fairly rapidly resolve the problem of micronutrient deficiencies and anemia. But they're really meant to be a sort of a shorter term solution and not necessarily get to the root of the problem, which I think is generally much more difficult to solve. And so really this angle of prevention is quite key. And from this perspective, I really feel like getting back to the basics of a healthy diet is so important. So having that access to a quality, affordable, and also diverse foods throughout the whole life course. And this is whether you're focusing on undernutrition or if you're focusing on overweight and obesity. As I mentioned, I really enjoyed skimming through this paper, and when I looked at that table of the WHO recommendations from ANC and the essential nutrition actions, at the very top there is that recommendation for counseling about healthy eating and keeping physically active during pregnancy. But what we really lack is the sort of how to do this counseling and what is really the meat behind the information that you're counseling the women on. And WHO does lack that guidance from that healthy diet perspective of how do we best reach our adequate micronutrient intakes through the available foods. And I think it would be really great if we could have much more attention in this area. The Food Systems Summit was great about bringing attention back to the foods that we eat and the systems for providing that food. And food fortification certainly has a big role to play in this area. So I think, really getting back to the basics of food, and also I was really reflecting on it's not just a food that's available and affordable. That's just one aspect, but you really nicely brought out in this document the gender inequalities, particularly as they influence the intra-household food distribution and women's empowerment as a fundamental human right, including access to quality and timely healthcare, education, and of course, ability to make the good decisions about the types and quantities of foods consumed, not only for that woman herself, but for her family. And also for empowering them to make decisions about the supplemental interventions that might be necessary from time to time. So I think bringing all these elements together, they're really, really difficult ones, but I think if we don't start addressing them in a more comprehensive manner, we're not going to be able to be moving out of this treatment into the prevention. So I think these are really helpful in bringing the food, the food that we do eat back to the center of our discussions, and ensuring that these women are empowered, enabled, and have the means to have access to quality food in sufficient amounts would certainly be a good measure to start with in preventing at least the anemia and the micronutrient deficiencies. So I think this is sort of where I hope to see the future activities going. And if I can just take a couple minutes to remark on some of the other points. Really happy to announce that the postnatal care guidelines in WHO are being updated, and they should be out in the next 2 months. I think we're really close. They're huge. They're just really comprehensive, and so I think that's going to be a really exciting thing. There'll be much press around it. So in the next 2 months, be looking for that guidance. On multiple micronutrient supplementation, I couldn't agree more with Marty and her remarks, and WHO is planning a technical consultation around some of the recommendations that WHO had put out and bringing the partners together to look at so what's happening. And I think the recommendation that you have into putting out a statement that we all can stand behind and help countries to move forward is an excellent recommendation, and we will certainly bring this to the table as well. So thank you for hearing that. And then also hearing on the gaps of the balanced energy and protein supplementation. I was listening with a very careful ear to Abby, and because this is also on our list of items to do within the next biennium, so 2022, 2023, and to bring out some of the implementation guidance. And so it's probably slated more for 2023, but this is something that we'd be happy to work with the partners on as well. And we know that it's a gap. So great to hear that we're aligned and moving forward on that. So thank you very much for the opportunity.
Thank you so much, and thank you for doing such a great job of helping us wrap up with all the different themes as well, Lisa. Thanks for joining us.
Yes, absolutely.
As Emily comes to wrap up, I will put my email in the chat. I'm aware we've run out of time for questions. If anything hasn't been answered, please feel free to email questions, and I will put them to the team and maybe the panelists as well, and we'll do our best to get back to you. But I'm glad we didn't cut any of that, because it was just absolutely fascinating and food for thought for the ways forward. Apologies for overrunning, and back to you, Emily.
Thank you, Phil. And thank you so much to our excellent panel of experts. We did set them quite complex questions for them to answer, but they really rose to the challenge and provided such useful information. So we thank you for that. So we're just going to put a very short poll with one question on the screen. If you're able to just answer how useful this webinar has been for you, it really helps us for the future, to do future ones. So also, as Phil said, he's put his email in. Hopefully you have our emails too. So do shout if you need more information or if you have any questions. And yes, all that's left is to thank all of our esteemed guests for joining us. Thank you all for your time, for listening and actively taking part. And once again, we'd like to thank our three main funders for supporting this work: the Bureau of Humanitarian Assistance at USAID, Irish Aid, and the Eleanor Cook Foundation. And have a nice rest of the day or evening to all of you. Thank you very much. Goodbye.